10 λεπτά για συζήτηση. Αυστηρά. Okay. Massimo, would you like to join me on the podium? Και εσύ, Γιώργο, έλα από εδώ. Υπάρχουν ερωτήσεις, σχόλια? Έλα, Ανδρέα.
This Petro, μία για σένα και μία... two questions, Peter, one for you and one for Dr. Levero. Regarding the experiments with in vitro cell lines, if one looks at the literature, you'll find different results, sometimes conflicting if you're using different cell lines. Those cell lines are immortalized and sometimes transformed, so the transcriptional machinery and the intracellular regulatory pathways are disturbed. The question is, does it even make sense to try to dissect the transcriptional machinery and regulation of the virus in such an environment? Of course, they're useful, but in your opinion, what are the limitations and how close they are to what really happens in the human liver? And for Dr. Levrero, if interferon has such a specific effect in terms of recruiting a silencer on the transcriptional activity of cccDNA, why is it not its effect more universal? Is it what you mentioned, why don't we see it in more patients? Is it what you mentioned at the end, that we're only affecting a subset of the molecules as transcriptionally active ones, or do you have a more sophisticated explanation for that?
Okay, if I could kick off with your first question. I think we're dealing with transformed cell lines, as you say. Probably they no longer behave like hepatocytes, a lot of them. But they're still good in giving us an indication as to whether some things are working properly. What they've been used mainly is not so much the precise study of what controls what, but in assessing antiviral treatment, judging how the virus is put together, and so on, but not in seeing how, for example, the co-promoter mutations work, and so forth. The second question?
Yeah. So, obviously we don't know why. Otherwise I would tell you before. What we know is that if you take interferon and you give to liver cells, that was done in several experiments, some on transformed cells, and obviously there are the limitations you were already mentioning and others. You have several genes that are repressed. So interferon does not have only the ability to activate transcription, but also to repress. And there are a subset of genes that are repressed by a mechanism that is related to the recruitment of a PRC2 complex. We published 2 years ago just one of these genes because it was interesting. It was an oncogene and was delta N, the dominant negative version of P73, member of the P53 family, so is a dominant negative tumor suppressor that becomes an oncogene. And so we were studying that and we published that. There are other genes in which the ZEST2 is recruited. Why no more genes, more widespread? Transcription, if you want to have a therapy that is based just on transcription, you are in big troubles because transcription is complicated, redundant, and you have many components that go together to a final. Some of the components are, let's say, long-lasting, and others are very rapidly counteracted by other things. So this is very likely all of us are different, the viruses are different, the people are different, the transformed cells are different from the hepatocytes. If you go to study just the primary hepatocytes, some things you cannot do. And again, the donor of the single batch of hepatocytes might be very relevant for some responses or others. So it's not easy to approach that. But just to answer specifically to the interferon, we know about ZEST2 and interferon. We know that core is repressing some genes, core, HBV core, and it does that partially through ZEST2 and much more through another histomethyltransferase that is called G9, that is very relevant for interferon responses. There is not so much in the literature, but the few things that are in the literature are on interferon. Before we were thinking that these complexes were separated, either you activate one or the other. In the last 2 years in molecular cell, and so on, we discovered that all these histomethyltransferase complexes that we thought were different complexes actually are different forms of a single big complex that can variate in conditions, in patients, in individuals, and so on. So why it doesn't work in everybody, we don't know. Will ever work in everybody? Probably if we expand the ability. That was a lead of what can happen, and there's an effect on transcription, that's clear. In vitro is in all the experiments, almost, and other groups confirmed that in different cells. So seems to be true. Why in the patients? Because the patients are more complicated than the cell line, and we don't know yet.
Άλλα σχόλια, ναι κύριε καθηγητά.
I enjoyed the presentation of all three of you.
Thank you.
Very nice.
Thank you, Stefano.
I have just a clinical point for you, Massimo. You made the point, I'm not a virologist, I'm not involved in immunology, just superficially. The point you made is that the e-antigen negative patients actually belong into subsets. And the one in the history of which you have e-antigen positivity and then you have termination into e-antigen negative and ongoing activity may be different from the other one, that it is prevailing both in Italy and in Greece, where the e-antigen positive phase is not recognizable, it's very, very short. Would you like to comment on this a little more?
Yes, I can make 2 comments, and I will ask to Peter to comment again on that, because I'm sure he has his ideas on that. I don't know, again, because we have to be fair. We don't know, we have to say we don't know. But I bet that you are right. A lot of things may be different according to how you become E-negative. And this is, clinically speaking, we have a lot of hints on that, but again. I think that one major point is time. So our old anti-E positive patient coming from Sicily, from Giovanni and Teresa, or from the little countryside around Rome, 20, 30 years of infection, seen as anti-E. We don't know whether, many of them with the mutant, some of them without. Yes. They had 25, 30 years of ongoing replication and adaptation cycles between the virus and the host and the immune system. And they have a bunch of mutation in the virus, not only the one that are well known, but also other one, the pre-S, pre-S2 especially mutation that were very well studied in Japan, in Sicily, and by others, might be very relevant. But I think that the most important point is time. We are dealing with patients that have a different story, different time frame. Most of the time we don't know. We don't have the way to really classify them. And think of something. Anti-PD-1, I'm not an immunologist. I always go with immunologists. I was an immunologist when I had the hair and I was very, very young. So it was in the pre-colonial era, so it doesn't count. Anti-PD-1, anti-PD-L1 therapies make a big impact on cancer, tumor immunology, and cancer patient survival by reactivating what is thought to be a completely fucked off immune system in cancer patients. Well, it works there, should work in hepatitis B, I'm not sure. The cancer patient has a time to death before the therapy that is much shorter than the lifespan of an infected patient with hepatitis B. And some data from the real immunologists that I have the privilege to collaborating with seems to say that the quality of the exhaustion, and I'm not talking about deletion, exhaustion, the quality of the exhaustion of the immune system, and in particular of the CD8 cells in hepatitis B patients is so deep that even the good immunologists, Carlo Ferrari, Antonio Bertoletti, Frank Cisari, they really have doubts, start to doubt, that you may easily restore, fully restore. You may restore a little bit, you may restore some patients, not others. But they really have to go much, much farther inside there. And the final results will be exactly what we are saying, that the patients have to be classified at least E anti-E, after for some of the mutations that in waves comes. Sometimes we do, now is a period that we don't do anymore. 10 years ago we were doing more, but we have to do all that. And probably some immunological parameters, even if they are not easy to categorize, but we have to do all of this. Remember Kennedy paper on the tolerant patient. We think all the immunotolerant is a very bad definition, but still, all the immunotolerant are the same? No, not at all. The young ones are much better. The Chinese ones that are 50 years old, E positive, are not immunotolerant at all, not in the same way. I don't know if you agree, but I think you agree.
I think it is very important to realize that in the anti-HB positive phase, the part of the virus that comes under attack is the core protein. In the immune tolerant phase, we see absolutely no immunology whatsoever or pathology in the liver. During the the immune activation and then the reactivation phase, when we see the liver damage in the liver, what happens in the immune active phase is completely different from what happens in the reactivation phase. In the reactivation phase, it's the core protein that gets the hit. And because of that, the virus feels the need to keep changing. So we see different core mutations appearing. Now, this, of course, creates a constant battle between the virus and the immune system. That's why we have the fluctuating transaminases and viremia.
How to classify it?
Exactly. What is selected depends on the host genetics, what is presented to the immune system. That's why we have such a variation in chronic liver disease during the E antigen negative phase. That's what I want to say, because Yanis is going to kill me. We've taken 15 minutes over. Thank you very much, and thank you very much to the rest of the speakers.